Hello everyone. So today we will talk about Guillain Barre Syndrome. Guillain Barre Syndrome, as if you are a final year student, it is a very important topic for the final year student. It can come into the exam and you can be asked about Guillain Barre Syndrome in your practicals also. It is a very important topic as you should know about the Guillain Barre Syndrome. So first we will talk about the definition of the Guillain Barre Syndrome. In definition, we will definition of the Guillain GBS is it is a heterogeneous autoimmune inflammatory condition. Sorry, I haven't mentioned here heterogeneous. Okay, it is heterogeneous. Sorry for the handwriting. It is a heterogeneous inflammatory condition characterized by the demyelination and axonal degeneration of the peripheral nerves, which results in acute ascending progressive neuropathy. So definitions का ये है कि it have the some standard definition from some standard book. You should know as it is. Definition from standard textbook as it is, you will know, you will learn it. It is a heterogeneous autoimmune inflammatory condition which is characterized by the demyelination and axonal degeneration of peripheral nerves, which results in acute ascending progressive neuropathy. Keyword here is heterogeneous autoimmune inflammatory condition causing the demyelination and axonal degeneration, which results in acute ascending progressive neuropathy. Okay, then we will talk about its pathophysiology, how it works. So remember the three key points here. That three key points is autoimmune attack, trigger and target. Autoimmune attack, that immune system mistakenly attacks its own body tissues. And trigger, this attack is often triggered by the molecular mimicry, where antibodies created after a recent infections mistakenly recognize and attack the peripheral nerve components because they share the similar molecular structures with the original infectious agent. तो यहाँ पे क्या होता है, जब कोई इन्फेक्शन हो जाएगा हमारी बॉडी में, तो इन्फेक्शन से क्या होता है, जो एंटीबॉडीज़ बनती हैं उनका स्ट्रक्चर और उनका मॉलिकुलर स्ट्रक्चर और जो हमारे पास पेरिफेरल नर्व कंपोनेंट्स का जो हमारे पास मॉलिकुलर स्ट्रक्चर्स, वो सिमिलर स्ट्रक्चर्स होने की वजह से जो हमारा जो इम्यून सिस्टम है वो मिस्टेकनली अपने ही बॉडी टिश्यूज़ को अटैक करना शुरू कर देता है. तो देयर विल बी the first line we have read that the immune system mistakenly attacked its own body tissues. Okay, there will be the molecular mimicry. This attack, there are some triggers like Campylobacter jejuni, CMV or Zika virus. There will be the molecular mimicry where antibodies created after a recent infection will mistakenly recognize and attack the peripheral nerve components को अटैक करना शुरू कर देगा. And this antibodies primarily target antigens on peripheral nerve myelin covering the spinal roots and the peripheral nerves. So most common cause is Campylobacter jejunum. Second most common cause is CMV. Other causes are EBV, HBV, SZV and mycoplasma. Then we will talk about GBS variants. Historically, GBS was considered a single disease entity. Now it is recognized as an umbrella term with the several variants. That is the acute inflammatory demyelinating polyneuropathy. First variant is acute inflammatory demyelinating polyneuropathy. The most common clinical form you will see is the acute inflammatory demyelinating polyneuropathy, which accounts for approximately 85 to 90% of the cases. Obviously we read about our some American studies or some African studies. Okay, then second variant is axonal variants. The axonal variants में first variant is acute motor axonal neuropathy. It is the purely motor involvement. In acute motor axonal neuropathy there is purely motor involvement, predominant in children and often seen in outbreaks in China and Japan. Second Axonal variant is acute motor and sensory axonal neuropathy. It is considered a severe form of axonal neuropathy, acute motor axonal neuropathy. Both the motor and sensory nerves are affected. Then there is a term pure sensory GBS. If someone asks you about pure sensory GBS, नाम में ही है pure sensory, that is the sensory loss. There will be sensory loss, there will be sensory ataxia and areflexia in a symmetrical and widespread pattern. And there is another term, there is the Miller-Fisher syndrome. Miller-Fisher syndrome, someone is asked you about what is the difference between GBS and Miller-Fisher syndrome, then you will say that in GBS, remember GBS is the ascending paralysis. GBS cause ascending paralysis, but in Miller-Fisher syndrome there is descending paralysis. Okay, you will remember it, there is descending paralysis. Descending paralysis. In GBS there is ascending paralysis, symmetrical ascending paralysis. In MFS there is descending paralysis rather than ascending paralysis, and it is a triad of OA. What is OA? O से ophthalmoplegia, A से ataxia, और then third A से areflexia. Ophthalmoplegia, ataxia, areflexia. Miller-Fisher syndrome, you should know what is Miller-Fisher syndrome, आपके knowledge में होना चाहिए. MFS, that it is causes the usually patient present with descending paralysis rather than ascending one, and patient will present with triad of ophthalmoplegia, ataxia and areflexia. Okay, then we will talk about epidemiology of the GBS. In epidemiology, first we will talk about the incidence. Incidence is approximately 1 to 2 cases per 1 lakh people per year. Then it is more common in males. Peak age is between 15 to 35 years and 50 to 75 years. Then we will talk about the clinical features. Onset of the GBS is subacute over days to weeks. It takes. Then core symptoms. 3 point you should remember in GBS at 3 most important, that it is a symmetrical ascending muscle weakness, ठीक है, starting in lower limbs and progressing to the upper limbs with areflexia. Loss of the deep tendon reflexes. 3 points: symmetrical ascending muscle weakness with areflexia. Okay, the patient, how will patient present? Sensory symptoms, patient will present with descending sensory dysfunction like numbness and tingling sensation and loss of proprioceptions and the vibration sense. So patient will present with symmetrical ascending muscle weakness with the loss of deep tendon reflexes, and there will be the numbness and tingling sensation and loss of proprioception and vibration sense. Autonomic dysfunctions, patient can present with orthostatic hypotension, and if this GBS progress, it causes some complication. If progression will causes it will ascend into the diaphragm, involving the diaphragm, which will causes the respiratory paralysis, respiratory failure. And if it involves the cranial nerves, it will causes the cranial nerve weakness, which will result into the facial paralysis, difficulty in swallowing or eye movement problems. And the most important and the most first symptom patient will have is pain in the lower back, as it causes the inflammatory damage to the spinal nerve roots. Okay, so in clinical features, 3 things we will remember is it causes symmetrical ascending muscle weakness with areflexia, symmetrical ascending paralysis, areflexia, loss of deep tendon reflex. Patient will present with numbness or tingling sensation, and there will be loss of proprioception and vibration sense. Which vibration, loss of proprioception and vibration you will check in CNS examination. Patient can present it with orthostatic hypotension, and if the GBS progresses, complication it can causes that it will ascend, causing the respiratory muscle paralysis, which will causes respiratory failure, involving the cranial nerves, which will causes the facial weakness, difficulty in swallowing or eye movement problems. And the first symptom patient will present with pain in the lower back as it causes the inflammatory damage to the spinal nerve roots. कुछ भी भूलना होगा तो बाकी चीज़ें भूल जाना, बस 3 चीज़ें. Symmetrical ascending paralysis it causes with areflexia. Okay, then we will talk about the investigation, how we will diagnose that it is GBS. So it is a clinical entity. हम पेशेंट के सिम्टम्स, क्लिनिकल फीचर्स के बेसिस पर डायग्नोसिस कर सकते हैं. एंड द इन्वेस्टिगेशंस वी कैन डू इज number important is nerve conduction study. We will do the nerve conduction study of the patient, and nerve conduction study we will see there will be the reduction in the nerve conduction velocity firstly. Okay, then we will do the CSF analysis. In CSF analysis there will be the immunocytological dissociation. Okay, in this, the most important point here is that ACD is typically present in albumiноcytological dissociation will present in about 50 to 60% of the patient in the first week of the GBS. But when around the second to third week, it will approximately in second week approximately ACD will be present in about 80% of the patient. So हम CSF fluid analysis कब कराएंगे? second week of the appearance of the clinical features में second week में कराना है CSF analysis. Okay, now most important nerve conduction study. Nerve conduction study में we will find that there is reduction in the nerve conduction velocity, and in CSF analysis we will see there is the albuminocytological dissociation, and it will present around second week. Okay, then we will talk about the treatment of the GBS. Treatment, we will remember 2 things in the treatment, that is the IV immunoglobulins and plasmapheresis plex therapy. IV IG we will give the patient, we will give to the patient is IV IG, doses 0.4 gram per kg per day for 5 days. This is the first line therapy. Then plasmapheresis 4 to 6 exchanges we will give over 7 to 4 days. Then one important point here is IV, IG and plex. These are equally effective. Neither is superior to the other, and combining them does not provide any added benefit and is generally not recommended. And one thing, Harrison book, one thing is mentioned that steroids also does not add any benefit or does not give any improvement to the patient, and not have seen that it improved the GBS, it improved the symptoms of the patient or have any benefit to the patient. So it is unnecessary to give the steroids. This one point I have to mention here. Then next we will talk about is complication. We have studied on clinical features, that if it progresses, GBS progresses ascends into diaphragm muscles, causing the respiratory muscle paralysis, which will causes the respiratory failure. Okay, it is the most serious complication as the patient will require the mechanical ventilations. Then it will cause the autonomic dysfunctions like wide and rapid fluctuation in heart rate and blood pressure. Pain, obviously it will causes the pain like radicular back pain, deep aching muscle pain, or dysesthetic pain. And if it involve the cranial nerves, it can causes the facial muscle weakness, it can causes the difficulty in swallowing, and it can also causes the pain. We have talked about facial nerve weakness, we have talked about difficulty in swallowing. And then as the GBS क्या करता है, ascending paralysis of the body करेगा, the patient will be bedridden for approximately long time के लिए. Then long time bedridden patient में एक most important complication, जहाँ भी long बेड रिडन पेशेंट आपको दिख गया है, जहाँ भी आपको कोई भी बीमारी में बेड रिडन पेशेंट है, लंबे समय तक बेड में ही है, खुद नहीं चल सकता, तो मोस्ट इम्पॉर्टेंट कॉम्प्लिकेशन द पेशेंट कैन हैव इज DVT. रिमेंबर इट. सो इन GBS ऑल्सो असेंडिंग मसल पैरालिसिस कर रहा है, तो देयर विल बी द DVT. ओके, so these are the complications of DVT. Then we will one thing I have want to mention here is prognosis. Prognosis, we will say that approximately 85% of the patient complete the recovery in about 3 to 6 months, and less than 5% mortality rate होता है GBS का. ठीक है. Other cares we can give to the patient is nutritional support through NG tubes, नेजोगैस्ट्रिक ट्यूब के थ्रू फीड करा सकते हैं, एज देर विल बी डिस्फेजिया को प्रिवेंट करता है. देन वी कैन गिव द ब्लैडर केयर इफ ऑटोनॉमिक डिसफंक्शंस अकर, and there can we can provide the physical therapy to prevent the contractures of the patient. So this is all about GBS. सो GBS में एक बारी छोटा सा रिव्यू कर देते हैं. फर्स्ट वी विल टॉक अबाउट द डेफिनेशन, दैट इज़ अ heterogeneous inflammatory condition, autoimmune inflammatory condition characterized by demyelination and axonal degeneration of peripheral nerves, which causes the acute ascending progressive neuropathy. Then पैथोफिजियोलॉजी में 3 थिंग्स वी विल रिमेंबर, दैट इट कॉजेज द ऑटोइम्यून अटैक, और जो ऑटोइम्यून अटैक होगा दैट इज ट्रिगर्ड बाय द molecular mimicry where antibodies created after recent infections mistakenly recognize and attack peripheral nerve component because they share the similar molecular structure with the original infectious agents, and target will be the antigen on peripheral nerve myelin and covering the spinal root and the peripheral nerve. Most common causes Campylobacter jejuni, CMV is the second most common cause. Then GBS variant we will talk about. Firstly, historically it was a single disease entity, but now it is an umbrella term with several variants. Number first is acute inflammatory demyelinating polyneuropathy. Then axonal variant में acute motor axonal neuropathy and acute motor and sensory axonal neuropathy. Then pure sensory GBS, I have taught you that is a sensory loss, sensory ataxia and areflexia, and asymmetrical and widespread pattern. And Miller-Fisher syndrome I have told you about it. It has the descending paralysis, presents as a descending paralysis or triad of ophthalmoplegia, ataxia and areflexia. Then epidemiology, incidence in 1 to 2 cases per 1 lakh per year, incidence more in male. And presenting feature, 3 most important that I have told you to remember, that is the symmetrical ascending muscle weakness with areflexia. Patient will present it with numbness and tingling sensation and loss in the proprioception and vibration sense. Autonomic dysfunction, it can cause orthostatic hypotension, and if it progression of paralysis, it will paralyzes the respiratory muscle paralysis हो गया तो respiratory failure हो जाएगा patient को. Then if it involve the cranial nerves, then there will be the facial muscle weakness, there can be the difficulty in swallowing, eye movement problems होगी, और the most important first symptom patient को आएगा, that is the pain, क्योंकि inflammatory damage to the spinal nerve roots हो जाएगा. इन्वेस्टिगेशन में हमने बताया कि ये क्लिनिकल एंटिटी है, और टेस्ट क्या करेंगे हम, नर्व कंडक्शन स्टडी टेस्ट करेंगे. नर्व कंडक्शन स्टडी में क्या होगा, कंडक्शन वेलोसिटी जो है कम हो जाएगी हमारे पास, रिडक्शन इन नर्व कंडक्शन वेलोसिटी होगा. ठीक है. और क्या कर सकते हैं हम, CSF एनालिसिस कर सकते हैं. CSF एनालिसिस में देयर विल बी एल्ब्यूमिनोसाइटोलॉजिकल डिसोसिएशन. okay, and we will do the CSF analysis in the second week, because in progress it is approximately 80% of the patient में ACD will appear around the second week of the GBS. okay, then we have talked about the management. How will we manage? We will give the IV immunoglobulin to the patient, doses 0.4 per gram per kg के हिसाब से for 5 days, और प्लैक्स देंगे, प्लाज्मा एक्सचेंज, प्लाज्मा पैरासिस देंगे, अराउंड 4 to 6 एक्सचेंज करेंगे ओवर 7 to 14 डेज में. और वी हैव टॉक दैट IV, IG एंड प्लैक्स आर इक्वली इफेक्टिव, और स्टेरॉइड्स मेडिसिन हैव मेंशन आर नॉट that much effective or have any effectiveness. Then we have talked about the complication, that is the respiratory failure, autonomic dysfunction. It will causes pain, it will causes DVT prophylaxis, it cranial nerves involvement हो गई, then it will causes the facial muscle weakness, difficulty in swallowing, eye muscles movement में problem होएगी. Then other cares, we can give us nutritional support to the patient, we can give the bladder care to the patient, and physical therapy we can give to the patient. न्यूट्रिशनल सपोर्ट देना है, ब्लडर केयर करनी है एंड फिजिकल थेरेपी देनी है. और we will have talked about the prognosis. Less than 85% of the patient make a complete recovery in a 3 to 6 months, and less than 5% is the mortality rate. Okay, so yeah, this is all about the GBS. बहुत important topic है, it can come into the exam. Okay, so this is all about GBS. First, this is all for today. Next I will come with another video, another important topic for exam. Okay, thank you.